Hello, my name is Jonathan Arp. I'm a firefighter paramedic with the City of Greenville Fire Rescue. I've been there for 13 years, about 5 of those being a paramedic. Today we're going to talk about diabetic emergencies. So what are we going to be learning today? We're going to be learning about diabetes, common types of diabetes, diabetic emergencies and how to recognize them, and how to treat diabetic emergencies. That's going to be our key points for this presentation. So let's talk about it for a second. What do you know about diabetes? What do you think of when you hear the term diabetic emergency? How do you treat a diabetic emergency? Those are some of the questions I'd like for you guys to think about as we go through this. So what is diabetes? The human body has blood glucose, aka blood sugar, which is used for energy. The normal blood glucose level, or the BGL, is around 80 to 140 milligrams per deciliter. You'll usually see that written out as mg/dl. The BGL is measured with a device that we call a glucometer. I'm sure you guys are probably familiar with this, but it typically involves pricking the finger with a little lancet, and then we take the blood that comes from the finger prick and we use a little test strip and the glucometer, and that is how we read the blood glucose level. The BGL, or the blood glucose level, is controlled by a hormone called insulin, and this is produced by the pancreas. Some bodies struggle to create the correct amounts of insulin to control the BGL, and some bodies do not create insulin at all. This condition is known as diabetes. Diabetic issues are typically controlled at home with ease. There are situations, however, that can lead to a loss of limbs or even loss of life if not properly managed and the person's BGL remains too high for too long. And so we'll break down a little more as far as the different types of diabetes. So the most common types of diabetes that we will encounter in the field as far as EMS is type 1 diabetes, type 2 diabetes, and gestational diabetes. There are some other types, but these are going to be the most common types that we'll encounter. So type 1 diabetes, the pancreas produces no insulin at all. This means that the individual will have to constantly monitor their BGL and inject themselves with insulin to control their blood glucose level. Insulin delivery can be done by either drawing up insulin from a vial and injecting it, or it can be done with an insulin pump. And what an insulin pump is basically like a small little computer, if you will, and typically there's a small needle that the user will wear, and then the insulin pump is regulated and they can control how much insulin is being injected, when it's being injected. And for type 1 diabetics, this is really a little bit easier to manage their diabetes versus having to have a vial and syringes and needles to manually draw it up and inject it. The type 1 diabetes, it can present at any age. Typically though, it will develop at a very early age, so young children or even early adults. But most people will go most all their lives with type 1 diabetes. The next one that we will encounter is type 2 diabetes. With type 2 diabetes, the pancreas does produce some insulin, but not well enough to properly regulate the body's glucose level. People with type 2 diabetes typically control their BGL with diet, exercise, oral medications, and in some cases insulin, although they are not insulin dependent like type 2 diabetics. People can develop type 2 diabetes at any age, and things such as obesity, family genetics, and even eating habits can contribute to developing type 2. So remember, type 1, the pancreas produces no insulin. Type 2, the pancreas does produce some insulin, but not enough to sustain. And then next we have gestational diabetes. Some women can develop diabetes when they are pregnant. This is called gestational diabetes. In most cases, the problem is resolved once the baby has been delivered. However, women who have had gestational diabetes are at a greater risk of developing type 2 diabetes later on in life. Management for this is pretty much the same as type 2 diabetics. With gestational diabetes, the pancreas is still producing insulin, but just like with type 2, it's not producing enough to sustain or to properly regulate the glucose level. And so the management for this is pretty much the exact same as type 2 in that they can control it with eating habits, they can control it with exercise, oral medications, and then sometimes insulin, but not like type 1 where they are insulin dependent. All right, types of diabetic emergencies. The most common types of diabetic emergencies that we will encounter in the field as far as EMS is hypoglycemia, hyperglycemia, hyperglycemic, hyperosmolar non-ketotic syndrome, or HHNS, that's a tongue twister, and then diabetic ketoacidosis, or DKA. So let's kind of delve into that and discover a little more about these. So hypoglycemia, as we're familiar so far with our learning, hypo is usually too little and hyper is too much. So hypoglycemia is when a person's blood glucose level has dropped below or too low the normal range. Signs and symptoms of hypoglycemia usually include sweating, shaking, nervousness, lethargy, altered mental status, and then the more severe it gets, you start seeing snoring respirations, and unresponsiveness. People present differently with hypoglycemia. For example, here one patient with a blood glucose level of 35 may be alert when oriented and even talking with you, and another person with the exact same BGL of 35 could be completely unresponsive. If left treated, hypoglycemia can be fatal. And so that's diabetes, and the way that it presents as far as emergencies is just a really peculiar thing and always has been to me. Just because the wide range of the way it affects people. So again, like this says, you can have somebody with a lower blood sugar or glucose level of even 20 or 30, and one person be talking to you just fine, and then the next person is completely unresponsive and near death. So it's just everyone's body is different and how it metabolizes. All right, treatment for hypoglycemia. Treatment for hypoglycemia varies depending upon the severity of the symptoms. The best way to treat it is with food and drink containing sugar or glucose until the patient is back to a normal range. However, this treatment is very important to remember this. This treatment only works if the patient is alert and able to do so without creating a choking hazard. So we don't want to go into an unresponsive patient and try to force food, drink, or oral glucose down their throat, because this is going to prevent an even more bigger problem. In more severe cases where you start getting into people who are combative or unresponsive, you will most likely have to start an IV and then administer dextrose, which is a simple sugar. And usually the way we present it, or the way that we give it, is what's called dextrose 10%. And it's usually in a bag that looks just like normal saline. So we'll start an IV and we'll hook that bag up and we'll try to titrate them back to a normal level. But you do have to be careful with that because you can overshoot the normal range pretty quickly. And then in some cases where you can't establish an IV, we have another option which is called glucagon. This comes in a little 1 milligram vial, and we can draw this up and give it via an IM injection, usually in the arm. And this is really the slowest method to try to get their sugar back up. But if you can't give them food or drink or oral glucose, you can't give them an IV, then this is really the only option we have. But this is also the longest to metabolize, so just be aware of that. All right, next we have hyperglycemia. This is when a patient's BGL is elevated above the normal range. Signs and symptoms are generally mild but include thirst, dry mouth, headache, and blurred vision. If left untreated, hyperglycemia can lead to HHNS or DKA, which is more severe. Here we have hyperglycemic, hyperosmolar non-ketotic syndrome, or HHNS. And this is when the BGL reaches a level over 600 milligrams per deciliter. Signs and symptoms of HHNS can include extreme thirst, drowsiness, confusion, and even seizures. If left untreated, this can be fatal. The next one that we will encounter would be diabetic ketoacidosis, or DKA. This is a condition in which insulin deficiency prevents the body and stops glucose from entering the cells for energy. This results in body fat being broken down into ketones for energy and causes the blood to become acidic. Signs and symptoms of this are vomiting, nausea, abdominal pain, shortness of breath, in some cases almost like a fruity or sweet type smell in the person's breath. It's really kind of hard to describe, but if you ever encounter it, you'll know it and you'll remember it. And if left untreated, DKA can also be fatal. So how do we treat hyperglycemia, HHNS, and DKA? We're somewhat limited on what we can really do to quickly affect the different ranges of hyperglycemia. The patient can be encouraged to take an insulin shot if they have insulin present and if they're alert enough to do so. That would be the quickest method for them to get their blood sugar back down. An IV can be started and the patient can be given a bolus of normal saline, but really all we're doing with this is just replacing fluids and electrolytes that are lost from urination. The biggest thing with these is they're going to need to be transported because, again, we're kind of limited as to what we can do in the field. And with hypoglycemia, a lot of times we can treat those and the patient will end up doing a no transport because they'll come back around to a normal level to be completely alert and oriented. Only in really severe cases do we end up usually transporting the hypoglycemic patients. So in conclusion, back to the key points, we talked about what diabetes is, the different types of diabetes, and then the different diabetic emergencies that we'll be dealing with and how to treat them. An estimated 1 in 10 Americans have diabetes. While most people manage their diabetes with no problems, some still have issues that turn into emergencies that we will encounter on a regular basis in the field. Remember these signs and symptoms, the key points that we talked about with both hypo and hyper situations. When you respond to one, try to obtain the BGL reading as early as possible with a glucometer. That way you're not delaying any kind of treatment. You can go on and start working on the patient. While hypo patients can often be treated with ease by EMS, hyper patients will need to be transported to the hospital in most cases. So this is question and comment time. I don't know if any of you are still curious about anything or have any questions as far as how to spot different things or the differences in the different types of diabetes, or any comments as far as maybe some event or circumstance that you've witnessed in the field, or concerns. This would be a good time for that. No one? All right, moving on. Finally, we have our references here. Most of this information that we had in this presentation comes from the authors here from an article called Endocrine Emergencies, which was from a postgraduate medical journal. And then another one was from an article called Diabetic Emergencies. The author's listed here, and this was from the British Medical Journal. So hope you all enjoyed the presentations. And again, just while it can be easy, diabetes can be very serious. And just remember the signs and symptoms that we talked about and how to recognize true diabetic emergencies. Families on scene, let's try to use them as resources to help us help the patient. Sometimes the diabetes can present as something maybe different, such as an overdose or things of that nature. So that's why we want to obtain a BGL reading as quickly as possible to try to go on and figure out if that's the issue or not. And even on codes, that's why we try to get a BGL reading early on, because that may be one of the things that's led to the patient not breathing, and that's something we might can correct. So I hope you all enjoyed the presentation. This concludes it. Again, my name is Jonathan Hart. I enjoyed it. Thank you.